Hello, my name is Dr. Kemi Doll. I am a double board certified gynecologic oncologist, and I am a health equity and clinical researcher, really focused on using research in order to understand how to improve survival for endometrial cancer, especially in the Black community. I'm going to talk to you a little bit about the background of endometrial cancer and the research that we do. First of all, what is cancer? There are a lot of ways to describe this. I try to be as simple as possible. Normally, what you can see on the left side of the screen is that we have a constant balance in our bodies between new cell growth and old cell death. New cells grow, they get old, they get mutated, and then they're supposed to die off. In cancer, this balance is completely out of whack, where we have too much new cell growth. When they get mutated, they don't die off and they continue to grow out of control. Essentially, cancer is an imbalance. There's a lot of things that influence this, but the bottom line is once cells have crossed over the threshold into cancer, they're growing way too much, they're not regulating themselves, and they can threaten our lives. What is endometrial or uterine cancer? Endometrial cancer occurs when cells in the endometrium, which is the inner lining of the uterus, become abnormal. They go through this imbalance and they grow without control. Endometrial cancer is different from other reproductive organ cancers. It's not the same as cervical cancer, which you can see on the screen grows on the cervix, the doorway or the window to the uterus. It's different from ovarian cancer, which grows on the ovary, or fallopian or tubal cancers that grow in the fallopian tubes. Endometrial cancer is its own disease or entity that grows specifically inside the womb in the inner lining, and it's really important for us to know about. Why? Because endometrial cancer is common. At this point in 2024, there are over 66,000 endometrial cancer cases every year, new cases in the United States. Endometrial cancer is 4 times more common than cervical cancer. We probably have an estimated 250,725,000 endometrial cancer survivors, but it's estimated that only 46,000 of these are Black women. That's unacceptable. The risk of Black women in the US being diagnosed with endometrial cancer is about 1 in 32 by age 80. If you're in a room of 32 Black women, one of those women will be diagnosed with endometrial cancer by age 80. To compare, for cervical cancer, it's 1 in 130. And for ovarian cancer, it's 1 in 70. So again, endometrial cancer is much more common than these other cancers. And just to note that these statistics are based on our national registry statistics that doesn't take information in on sex versus gender. So this is the best statistics that we have for cisgender women. How deadly is endometrial cancer? The thing about it is that most people survive if they are diagnosed at earlier stages, when the disease is localized to the uterus, limited to the uterus. As the disease progresses and it goes to the regional area or the pelvic region or even distant, moving to the upper abdomen and beyond, that survival rate drops from almost 95% down to under 20%. And unfortunately, Black women are more likely to be diagnosed at the later stages, and really anyone with a uterus. This is a major problem, and we can see it in our national cancer statistics. The racial disparities in endometrial cancer survival are unacceptable. The purple line at the top is the rate of Black women dying of endometrial cancer. The pink line at the bottom is the rate of white women. Black women have double the chance of death after endometrial cancer compared to white women, and it's getting worse. It's one of the worst disparities we have in all of cancers in the United States. So, what are the signs of endometrial cancer? We need to know about this so that if it happens, we can diagnose it at early stages. Very heavy, abnormal, or any amount of postmenopausal bleeding could be early signs of endometrial cancer. I'll talk about both of those a little more. Some people with endometrial cancer will also have active menopausal symptoms, pelvic abdominal pain, changes in their usual bladder or bowel habits. But for some, bleeding is the only symptom, which is why it's the one that we really pay attention to the most. In gynecology, we have a few tools to evaluate the causes of abnormal bleeding. And this is really focused on that postmenopausal bleeding, bleeding that happens after the menopausal transition, which we generally think of after almost or around 12 months of no bleeding, and bleeding starts to pick up and get heavier again. We can use a transvaginal ultrasound to look at the uterus. We can use an endometrial biopsy to take a sample of tissue from inside the lining of the uterus that actually samples the entire lining of the uterus from the very top out. Or we can use a dilation and curettage and hysteroscopy, or a DNC, which is where we use a camera to open up the uterus, be able to look inside and take a bigger sample from the endometrial cavity. These are three equally offered options from our clinical guidelines. And what we know from doing a national survey of doctors across the country, both OBGYNs and non-OBGYNs that also see older women patients, family medicine doctors, internal medicine doctors, etc. Also nurse practitioners. We found that they overwhelmingly prefer starting with ultrasound. About 5 out of 10 or 54% chose ultrasound. About 36% or 3 to 4 out of 10 chose a biopsy or a DNC to investigate abnormal postmenopausal bleeding. Our current clinical guidelines do allow starting with a vaginal ultrasound in a way that on the surface makes sense. You do the ultrasound to measure the thickness of the endometrium, which is the lining of the uterine wall. That thickness then tells your doctor whether or not you need a biopsy. The idea is if the endometrium is too thick, a cancer could be there and a biopsy is needed. Here's the problem. That measurement doesn't perform as well in Black individuals. We started asking this question just simulating a cohort of people, so not with real medical records, but using various published reports. And it suggested that we might have a problem, that when we look at Black individuals over 45 compared to white individuals over 45, we found that using this transvaginal ultrasound technique specifically could result in nearly 30% better performance among white individuals with a uterus compared to Black ones. That's not good, especially considering that Black women, Black individuals with a uterus, are much more likely to have the most aggressive types of endometrial cancer. So we went a step further to really understand if this phenomenon was happening in real time. Why could this be happening, though? One of the ideas that we thought of, is that, we know Black women are much more likely to have fibroids, non-cancerous growths in the uterus. That's what fibroids are. Black people have larger and more fibroids than other groups of people, and also fibroids that persist later in life, so even through the menopausal transition. Fibroids can make it harder to correctly measure the endometrium when you're looking on an ultrasound. So we looked at over 3,500 Black patients in North Carolina. This was a large study that took 3 years to complete, where we were able to gather records on all of these individuals who underwent a hysterectomy. So we knew exactly what was going on in their uterus because they ultimately had a hysterectomy, but we were able to also look before at all of their medical records to see what was going on and whether or not ultrasound was helpful in diagnosing endometrial cancer. Just to give you a sense of who was in our study, their ages varied from age 21 to 90 years old, with an average age of 47. Half of these individuals had pelvic pain, nearly half of them had an enlarged uterus, and nearly half of them had anemia. So these were people pretty symptomatic from their uterus. 77%, most had fibroids, 70% had some kind of abnormal bleeding, and 15% specifically had the postmenopausal bleeding. They also had other symptoms. 20% had urinary bladder symptoms, 15% had active menopausal symptoms. They were going through it. And 22% had a history of an abnormal pap smear. Of all of these people that underwent hysterectomy, 404 or 12% ended up having endometrial cancer. and 3,551, or 88%, did not have endometrial cancer. Because we had both of these groups, we could then look to see whether ultrasound was helping to predict who had endometrial cancer. Before I get to the results, I wanted to give a little note about including our gender expansive individuals in this data. This group included both cisgender women and gender expansive individuals who identified as either trans or non-binary in the medical record. There were 17 total gender expansive individuals in our cohort, which amounts to about 0.5% of the population, which is about on par with what we see in national statistics of trans and non-binary individuals. 9 out of the 17 of these individuals, or 53%, had their hysterectomy reason related to gender dysphoria. After hysterectomy, none of these individuals were found to have endometrial cancer. They did tend to be younger in our cohort, and endometrial cancer risk tends to increase with age. Their diagnosis did include an atrophic endometrium, which means an endometrium where there's little growth happening. So their diagnoses after hysterectomy included an atrophic endometrium, where there is little growth happening, endometrial polyps, fibroids, and a proliferative endometrium, which means that there's a lot of endometrial growth. So there was a lot of variety, but there was no cancer. However, we did look at who had cancer. And specifically, we looked at that ultrasound result for endometrial thickness, which is here. And these are the different measurements. Who had endometrial cancer, who didn't, and what was the chance of missed cancer. As you can see, at each of these different thresholds, 3 millimeters, 4 millimeters, or 5 millimeters, there were endometrial cancer cases underneath the measurement threshold, meaning the threshold that's supposed to reassure us that there's no cancer, people still had cancer. And you can see the chances here of a missed cancer at each threshold. About 4%, 3.8% at 3 millimeters, 9.5 or almost 10% at 4 millimeters, which is the most commonly recommended threshold to use, or 11.4% at 5 millimeters. What this means is that ultrasounds in real individuals who underwent care missed up to 11% of endometrial cancer among Black people. When we looked at different subgroups, because we wanted to understand maybe the ultrasound works better depending on your characteristics, what we found was similarly troubling. When we restricted only to those over 50, we still had a 12.8% risk of missed cancer. When we restricted to those with a BMI of greater than 40, because that is a risk factor for endometrial cancer, still a 9.3% chance of missed cancer. Fibroids, 13% risk. People with pelvic pain, 14% risk. And people with a partially visible endometrium. This is very important, meaning that on the ultrasound report itself, it said they couldn't see the endometrium as well as they needed to, 26%. So we continue to look at this research to understand more features. For example, what are the risk factors that might lead to an inconclusive ultrasound? What we found, unfortunately, is that a lot of these women, they did not even have measurements on their ultrasound. Either their endometrium wasn't measured or it wasn't visible at all. And this was really common among patients with fibroids or an enlarged uterus. They were much more likely to have inconclusive ultrasound results. So a biopsy or DNC with hysteroscopy for this group of individuals was super important. In conclusion, ultrasound alone is not reliable in determining if someone needed a biopsy or not in this cohort of Black individuals. We say that because 1 in 10 patients with endometrial cancer had thin endometrial measurements that could have been falsely reassuring. We think that this contributes to the fact that Black individuals, Black women specifically in our national statistics, are diagnosed at much later stages of endometrial cancer. And furthermore, patients with fibroids or an enlarged uterus were more likely to have an ultrasound that didn't include an endometrial measurement at all, which is a problem because it doesn't give information about endometrial cancer, or had a measurement that was partially visible, which means it's not the best information for endometrial cancer. These people definitely probably need a biopsy or a DNC in addition to ultrasound when evaluating for abnormally heavy or postmenopausal bleeding. For these reasons, our team is educating and empowering Black people to talk to their providers about a risk-based approach for endometrial cancer detection. This is our campaign called Guides by Us. We want to educate our communities because we know that early detection saves lives. You can find a lot more information about the research we do at gracecenteruw.com. Thank you so much for listening.